Hey, everybody, can you hear me?
Yes.
Yes.
Good, 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 good. I'm going to turn my volume up here. So who do we got here? It sounds like Vicki Buchanan for one.
Yes.
Got Vicki. It looks like we have Mark Ward might be with us. Jennifer's with us. Looks like we got Andy Cahoon from North Carolina.
Good afternoon.
Good afternoon. Looks like we got Bill Dodson from Texas with us. Okay. Okay, guys, can you see my screen?
No.
No. Okay, so just like last time, I need to figure out how to share my screen here. Bear with me while I work through this. How about now? Can you hear? Can you guys see my screen now?
Yes.
Okay, good, good. So I'm going to make sure that I unmute everybody here. So I've unmuted everybody, so should be able to participate here. And again, Andy, Jennifer, Mark, Vicki, Bill Dodson, and Mark, you're logged in twice, for some reason. I'm not sure why.
I had to give Dick Stewart the link.
Gotcha.
Yeah, I didn't get that. Can you hear me, Mark?
I can hear you.
Yeah.
I didn't get that link on the. I got your email, but I didn't get the Zoom link.
Okay.
I got a Google Groups link.
Okay. So you didn't get the reminder from Demi about the link to the meeting?
I didn't.
Okay.
Mark.
Do you want me to forward it to you?
Mark did.
Okay, Mark did. Okay, good. Good. Okay.
Mark, Demi told us that we needed to reapply if we wanted CEUs for it. But if you didn't reapply after that, you're not getting the link because I didn't get it the first
Okay.
week.
Okay.
Oh, I'll probably have to do that, Vicki.
Okay. So guys, so for this evening, maybe a slightly more of an intermediate, type of a webinar here, and this is, again, going to be one of these that's going to be, interactive. So you're going to have to, participate here, and what I'm going to do is I'm going to show some videos, I'm going to show some vignettes, and then we'll do a case. Can anybody guess what the topic of our webinar is today? considering the name of it is junction, what's your function?
Neuromuscular junction.
Neuromuscular, yes. The dreaded neuromuscular junction. And, one of my favorite structures in the body, because even though we may not be actively trying to assess the integrity of the neuromuscular junction, sometimes we'll blunder right into it. Okay, and we'll have to be able to recognize when we do that, and then of course, as you become more seasoned electromyographers, you're going to need to be able to recognize the clinical signs and then the electrodiagnostic finding in suspected cases of neuromuscular junction disorders here. So the first thing we're going to do here is I'm going to show a video here, and sound is important. So I'm going to put my little microphone right up next to my speaker, and hopefully, you'll be able to hear, what's going on. So what we got here is we've got a standard monopolar EMG needle into a muscle, and this is at rest. And so you're seeing these waveforms at rest. So just watch and listen. Okay, so were you able to hear that?
Yes.
Yeah.
Okay, so taking a look at these things, you can see that some of them have initial, negative. Some of them have initial positive deflections here. So here are the questions that are associated with this, and I'm going to play this again, one more time. Okay, so question number one, what are these?
Are these motor in-plate potentials, or?
They certainly could be. They certainly could be. Okay, and you are correct. These are end-plate potentials and end-plate spikes. And again, what's the difference between an end-plate potential and an end-plate spike? Some people say it's the direction of that initial deflection. Some people would say that if it's a positive deflection, it's an end-plate, potential. Some people say if it's a negative, deflection, that it's an end-plate spike. But they're the same thing. Okay, and somebody tell me, when you see these during your exam, what is that indicative of?
You are near the neuromuscular junction?
Well, you're more than
You're on. You're in.
junction. You are literally in. You have succeeded in placing the tip of your needle into that neuromuscular junction. So that is correct. Okay. Somebody, just for academic purposes, somebody tell me what the significance is of an initial negative deflection versus an initial positive deflection. What does that signify?
The distance of your needle from the motor unit? Close. Okay.
Basically, it is indicative of the position of your recording electrode to where that waveform is being generated at. Okay. So if you've got an initial negative deflection, that means that your recording electrode is directly over the point at which the waveform is being generated. Whereas if you have a positive deflection, that means that your needle is distant to where that waveform is being generated at. Okay, so I mean, so that's what the significance is. If you look at our screen here, we've got a couple of end plate spikes that are being generated right at the point where the tip of our needle is. Whereas with this one here, because we have that little positive deflection, you know, that is indicative that the tip of our needle is not directly over the point where that, you know, waveform is being, you know, is being generated. And we've got some more participants here, so I'm gonna unmute these guys here, give them a chance to join us. We've got Shelley Lewis, we got Roy Adams, and then we got Kelly Comstock from way up in Alaska.
Yes, indeed.
Okay. So, third question here. Okay, how would you describe the firing pattern of these end plate spikes? And this is important. I mean, this is of critical importance.
Irregular.
Irregular. Okay. Because these things look like what? I mean, what other spontaneous potentials do these look like?
Positive fibrillations.
They look like fibrillation potentials. Okay. And the only way that you can differentiate a fibrillation potential from an end plate spike is by what?
Well, a fibrillation potential is going to be regular.
Is going to have a regular firing pattern.
Yeah. Whereas the other one won't.
Whereas the end plate spike or the end plate potential will fire irregular. Okay, so that's a critical piece of knowledge, you know, to be able to understand and comprehend. Is if you're suspecting, you know, that these are you know, fibrillation potentials, what's gonna help you to make that, you know, exact determination is the way that these things are firing. Typically, a, you know, fibrillation will look more like this guy here. It'll have an initial positive deflection. Can a fibrillation have a negative deflection? Is that positive? I mean, is it even possible?
I don't know. You said it had something to do with where the needle was placed.
It absolutely does.
I'm going to
So,
say yes.
so Mark says yes. Okay. Yes, a you know, fibrillation, although typically when we see them, they have positive deflections. If the tip of your needle is what is actually causing those fibrillations to fire off, you could potentially see fibrillations that have an initial negative deflection. But the way to determine whether they're fibrillations versus end plate spikes is by the firing pattern. Okay, and again, you know, a fibrillation is going to have a very regular rhythmic firing pattern, whereas, you know, an end plate spike is going to be firing irregular. Okay. Can we see this waveform in normal muscle? Or do we only see it in a muscle that's undergoing a disease process?
You could definitely see this in normal muscle.
Yeah, yeah.
If you're at the end plate, then it could be very well seen in a normal muscle.
Absolutely. I mean, this can be seen in normal muscle. It can be seen in abnormal muscle, as long as that motor unit still has an intact neuromuscular junction. You can see these. Okay, so these can be seen in both normal or, you know, abnormal muscle. How would you describe the morphology of these waveforms, especially when it comes to duration?
decreased duration or low?
Yeah. I mean, it's, we don't want to say decreased duration. We want to say short duration. But yeah,
Sure.
typically, these things have a very short duration, typically around 5 milliseconds or less. So that certainly is, a big indicator. If you're seeing what you think are end plate spikes, and it's got a duration of 10 or 12 or 15, 20 milliseconds, you're probably not looking at end plate spikes. You're probably looking at some form of a fasciculation or something like that. Okay. So again, normally these things in terms of morphology have that sort of spike shape. They can be biphasic or they can be triphasic. And here on our screen, here we have a biphasic, here we have a triphasic on a waveform here. But the key in terms of describing the morphology is the spike type of morphology that is of short duration. What does each of these spikes actually mean? What is this spike indicative of?
A discharge of the synapse?
Yes, we've got the needle in that neuromuscular junction, but it's recording this. So what actually are you recording?
Is that the acetylcholine or something?
Yeah. You're actually recording the spontaneous depolarization of a single muscle fiber as its quanta of acetylcholine, makes its way across the neuromuscular junction and binds with that, acetylcholine receptor there. So again, the important take home is this is as basic as you can get. Again, a single quanta of ACH binding on that postsynaptic membrane and spontaneously depolarizing a single muscle fiber. What is another name for each individual potential? A little bit trickier question. If you go into the research and into the literature, you may see it called a muscle fiber action potential. Okay, we call them end plate spikes or end plate potentials. But since it does involve the depolarization of a single muscle fiber, you will see these things called muscle fiber action potentials. And we've talked about this. I sort of let the cat out of the bag. What is the significance of that, positive deflection? And that significance is that your recording needle is distant from the point of propagation of that potential. And somebody actually went in and did some research, and in order to get a positive deflection, the distance has to be greater than 0.4 millimeters, okay, which is not a lot of distance, but when you're dealing with individual muscle fibers, that certainly could be. Okay, so guys, when we see these things, again, they're firing spontaneous. Okay, what's that patient going to tell you when you put that needle into that neuromuscular junction?
It hurt.
Yeah. They're going to say this really hurts here. Move it. Okay, and then as soon as you move that needle out of that neuromuscular junction, then the end plate spikes are going to disappear. Okay. Again, second big take-home point is in regards to the firing frequency. End plate spikes fire irregular, whereas a fibrillation potential is going to fire on a very regular, rhythmic type of basis. Was there a question?
Dr. Brooks, can you hear me?
I can. Jennifer, right?
Oh, okay, yeah. I've been like answering questions, but my mic wasn't working, and I think I finally figured it out. So never mind, I'm good.
Okay. Good, good.
I was like, why is he ignoring me? Okay.
Well, I've certainly unmuted you, but you let yourself
No,
mute.
I think it was my computer, but I
Okay.
fixed it.
Gotcha.
Okay.
Okay, so now I'm going to show you another on a video. This again is a monopolar needle stuck into a muscle, and I've isolated a single motor unit, using the trigger function. And what we're doing here is we're basically contracting to the point where we're firing one motor unit, okay? The computer is triggering on that, which means that it is isolating it. But this is from a clinically weak muscle, and I want you to watch this and tell me what you see happening. Okay, so let's go ahead and watch it one more time, and let's answer this first question. What is happening? What is happening with that waveform during the contraction?
With repeated firing, the muscle's getting weaker.
Yes, but what is the waveform doing?
The amplitude is
Amplitude is
decreasing.
diminishing. Yep.
Yeah, it's transiently changing amplitude. It starts out pretty large, then it gets smaller, then it gets larger again. Watch it one more time. It starts out off of the screen, and now it's getting smaller. And it'll shoot up bigger again. Okay, so this thing is changing amplitude. Okay, so again, during that very gentle, muscle contraction, we shouldn't see any significant change in amplitude. Okay, but this thing is changing here. So, what are reasons, either technically or perhaps pathologically, why a single motor unit would be changing amplitude?
I mean, is it possible that your needle is kind of shifting in the muscle as they're contracting?
Yes. That's actually the most common technical error. Okay, and that's where you have to have really good needle control here. What else? What are other reasons?
They start contracting a little softer or harder.
Usually, yeah, that could, but usually what happens when someone
fires more frequently,
it'll fire faster, or it'll bring in a second motor unit.
Right. Okay.
There.
Yeah,
Right.
That's true. Okay.
What could be happening on a pathologic basis that would make that amplitude change and make that amplitude be variable, assuming that your needle position is stable and that you're maintaining the same level on a muscle contraction?
Depletion, I mean, physiologically, depletion of neurotransmitter or synaptic.
So what is the I'm assuming this is Kelly, right?
It is.
Yeah. So what is the neurotransmitter that crosses the neuromuscular junction and causes the muscle fibers to fire and to eventually cause you to have a motor unit action potential?
I think I got this one wrong. I think I thought it was K plus, but wasn't it C plus, C calcium?
Well, calcium is what allows the vesicles containing this neurotransmitter to be on a release. But what is the neurotransmitter? Somebody?
Acetylcholine.
Acetylcholine. Absolutely. Okay. And so in the neuromuscular junction, disorder, there's typically one of two types of pathology. Okay. On the nerve side, typically the issue is some irregularity in the ability of that terminal axon to release its acetylcholine. Okay, so not enough, acetylcholine is being released. Whereas on the muscle side, on that postsynaptic membrane, typically the issue is with the ability of that acetylcholine to bind to its on a receptor. Okay, so when you see variations in these amplitudes, that is not technical. It has to do with either the amount of acetylcholine that's being released on the presynaptic side, or with the ability of that acetylcholine to bind with its receptor on that postsynaptic side. There's another reason here. In older EMG machines, and when I say older EMG machines, I'm talking 15 to 18-year-old machines, there's a phenomenon called aliasing, where the computer software and the computer processor just isn't functioning fast enough to keep track with all the data. This technical thing has pretty much been eliminated with our new systems. So typically, if you see this happening with a motor unit and it's technical, it's due to that needle tip moving. Okay, but if you've got good needle control and the patient is stable and the patient is contracting at a consistent level, then the issue is going to be with either the release of that acetylcholine or the inability of that acetylcholine to bind on that, onto that postsynaptic membrane.
Can I ask you a quick question?
You can.
Why have I not seen this Cascades version of the muscle contraction with the needle in any of our classes?
Because we have done this in the past. This is sort of a specialty type of testing that is not routinely done unless you are suspecting that the patient does have a neuromuscular junction disorder.
Got it.
And even with that, okay, there are other tests that I'm going to show you that are easier to do, okay, that will routinely turn the problem up for you before you have to get to this point, okay?
Right.
But certainly all of your machines have a trigger function, okay? And this is something that, again, if you've got an hour of time to kill between patients, or if you're one of, like these people in Alaska that like to take their EMG machines home with them at night, and practice on their husband or something like that. All these machines have this trigger function. And basically what you're doing is, once you isolate a single motor unit, you basically click on it, turn on the trigger and click on that motor unit, and it's going to put that motor unit into the center of your screen. And every time that motor unit fires, you're going to see this cascade.
Got it.
Okay, so it's basically a tool. Okay, it's a tool that, in most cases of neuromuscular junction disorders, you may never have to use. Okay, but it's there in the toolbox if you want to use it. Somebody tell me give me two types of pathology in which you can see a variability, like we just demonstrated.
Muscular.
Myasthenia gravis.
Myasthenia gravis. Okay, who said that? Was that
Vicky.
Vicky? Vicky, is that a presynaptic or a postsynaptic condition?
Well, I got a 50-50 shot, but I'm not
Yes,
good
you
at that.
do.
So I'm going to say it is postsynaptic.
It is postsynaptic. Okay, myasthenia gravis is a condition in which the acetylcholine receptors become damaged, or they become inhibited from working by antibodies. Okay, so in myasthenia gravis, there's plenty of acetylcholine being released. There's
But
just
not enough nicotinic receptors.
there are not enough functioning receptors to be able to take it all in. Okay, what is the other type?
Lambert-Eaton.
Lambert-Eaton. Okay, and you've got 100% chance of getting this right, Mark. Is
Yeah.
that a presynaptic or a postsynaptic?
Well, it better be a presynaptic.
It is presynaptic. And what happens in Lambert-Eaton syndrome? Also called myasthenic syndrome, just to make you even more confused.
That's nice. I imagine it's the one where it says the acetylcholine is not being released properly.
That is correct. Okay, there is not sufficient acetylcholine being released because the vesicles that contain the acetylcholine, due to pathology, are not able to migrate, to that neuromuscular junction in order to release its acetylcholine. Okay.
Mark, going back to like my first class ever 5 years ago, can you also check that with the stimulator, the nerve conduction stimulator, where you put it to fire repeatedly?
Oh yeah. We're going to talk about that here in a minute.
Okay.
So don't steal too much of my thunder here.
Sorry.
You can usually pick these conditions up just using our routine nerve conduction studies. Okay. Can you see variability in motor unit amplitude in normal muscle?
Yes.
Yes. And typically it's going to be something technical there. If you've got good needle control and the patient is, contracting smoothly and not jerking or cogwheeling, typically you won't. Okay. But if there's any type of technical problem, you can see this in normal muscle. And keep in mind also that these that these neuromuscular junction disorders are really not muscle problems. Okay, they are not myopathies. Okay, they're a condition typically, again, like we talked about, that either affects the neuromuscular junction or affects that terminal axon and inhibits the ability of that terminal axon to release the neurotransmitter. Good. Okay, so let's turn it up here. Let's go to even a higher level here. So in your training, you're not going to learn how to do what's called single fiber EMG, okay? Because that's a very time consuming technique, involves expensive needles. But what we got going on here, and again, the reason I'm showing this to you is you have to know this as part of your body of knowledge when it comes time for you to take your boards, okay? So what we got here is very similar to what we had on the previous one, but instead of using a monopolar needle, we're using a single fiber needle, okay? And a single fiber needle is a very small muscle that is designed to be put right next to adjacent muscle fibers. And one part of the needle is going
It's a
to,
very small muscle or a very small needle?
it's a very small needle designed to be put between two muscle fibers.
Got it.
Okay. And one part of the needle is going to record off of one muscle fiber. The other is going to record off the second muscle fiber. But the trick here is they have to be in the same motor unit. So you literally might spend 15 to 30 minutes trying to place this needle between two muscle fibers within the same motor unit. And, that's why this is, technically demanding, takes a lot of time. And there are other tests that you can do that might get you to this point. Okay. So what you're going to see on the screen is you're actually going to see two motor units, or excuse me, two muscle fibers firing, but they're from the same motor unit. You can see that we're triggered on the first, and then we have a second one firing out, over here.
That's a muscle fiber and then another muscle fiber. So
these are the depolarizations of two muscle fibers in the same motor unit.
okay.
Okay. Now these are not motor unit action potentials. Okay. A motor unit action potential is a summated response, perhaps of hundreds of different muscle fibers. These are two individual muscle fibers. Now, notice before I go to the next screen, here's the primary, and you can see how these line up perfectly, okay, because they're being triggered. But the secondary response, notice how they don't line up. Okay, notice how there is variability in the time in which they're firing, and also notice that in some instances it didn't fire at all. Okay, so let's go through our questions. Okay, I've done told you, what test is being performed. This is called single fiber EMG. Okay, the second question is that, well, actually, let me play that video once more so we get to that, down to that finish point. Okay, so the second question is that random time variability, which is this here, okay, in that second paired potential, what is this random time variability called? What is that term that we use to describe that time variability?
Some kind of a lapse.
Yeah, Vicky and Mark, you guys will probably kick yourself here in a second because you guys have heard this before, but unless you're doing this, this gets sort of lost back in the memory banks. Okay, so with single fiber EMG, we're looking at two things. We're looking at the variability of the firing of this second paired potential. Because if these were two completely normal, healthy muscle fibers, they both should look like this, okay? But here we're seeing, variability. And that variability is called jitter, okay?
Yes,
And,
I have heard that.
Yep, and we actually have normative values for different muscles, like muscles of the eye versus the deltoid, tongue. We actually have normal values for how much jitter there should be here. Okay, this is abnormal here. This is increased jitter. Now, we also noted that from time to time, this second paired potential wouldn't even show up. Did you all see that?
Yes.
Okay. It would disappear and then it would come back. Then it would disappear again. What is that called?
Absence.
Good try. That's called blocking. Okay. So when we're analyzing the results of single fiber EMG, the two parameters that we're looking at are jitter and blocking. Okay. So why would we have increased jitter in this second paired potential? I'm sort of giving you the answer here.
Yeah, it's like I can read it.
Yeah. It's because, again, there's issues with the release or binding of that acetylcholine.
Mm-hmm.
Okay. And because the acetylcholine is not being released on a regular basis, or it doesn't have the ability to bind, when it pops up that second potential, fires that second, muscle fiber action potential, the ability of it to fire at the same rate as the first potential is variable because of the abnormality in the release or binding of that acetylcholine. Okay.
Can I ask you a question?
Yes.
Is there ever that both are blocked and you have jitters and both?
Yes.
So we got lucky for a comparison.
Well,
so
and guess what you have to do if your primary fiber is being blocked? You've got to move your needle, and you've got to find one that's not being blocked. And that's why this is so time consuming, to do this. Is you literally might spend 30 to 45 minutes to get 5 seconds worth of data.
Sounds awful.
It is a challenge. I have done it.
Oh, wow.
It's a challenge. But this is a very, very useful test. Okay.
So it's very specific.
It's very specific. Okay. And it's very specific for disorders of the neuromuscular junction.
Mm-hmm.
Okay. So typically, the reason that we do single fiber EMG is if our standard nerve conduction tests don't get us to the answer, if repetitive nerve stimulation doesn't get us to the answer, if our needle EMG, our standard needle EMG doesn't get us to the answer, this is sort of our last resort. Why is that second potential sometimes being blocked? Why are we sometimes not even seeing that second potential?
Either there's no acetylcholine available.
Yeah, there's either no acetylcholine being released at that point in time, or that receptor is either occupied or damaged at that point. Okay. So again, we're looking at two parameters here. We're looking at jitter, which is that time variability, and we're looking at blocking. And in a normal muscle, there should be minimal or no blocking whatsoever. Okay.
I have a question, Dr. Brooks.
Yes.
If the receptor was actually damaged, wouldn't it be blocked every time?
If the receptor is physically damaged, it's not going to release or be able to accept any acetylcholine.
So it would be blocked every time.
It would be blocked. Typically, a more typical pattern would be is because of the impaired release of that acetylcholine, that when the next quanta gets to one of the few remaining functioning receptors, it still may have a molecule of acetylcholine that hasn't been broken down yet, and thus you won't see that second potential there. That's a more typical thing that that will happen. Okay, so again, jitter and blocking, what to on the conditions, neuromuscular junction pathology is typically the one that you will see it used the most for, but it can also be seen in motor neuron disease. Okay, because why would we see neuromuscular junction disorder type stuff happening in a motor neuron disease? How is that possible?
Because it's a partial motor neuron disease doesn't mean there isn't nothing happening. It's still trying to fire, but there's something wrong.
Right.
Right. Going
right.
To the motor unit.
Right. Motor neuron problems can affect any part of the motor neuron. Okay. What are the 4 components of a motor neuron?
Axon, hillock, axon.
Starting proximal and going distal.
Cell body.
Which is the
cell body.
Which is what is the motor cell body called?
Oh, the anterior horn cell? Or?
The anterior horn cell.
Yeah.
Okay, so the anterior horn cell is connected to the
axon.
To the motor axon. The motor axon is connected to the
dendrite.
To the neuromuscular junction, and the neuromuscular junction is connected to the
muscle.
To the muscle. Okay, so motor neuron disease can affect the cell body. It can affect the anterior horn cell. It can affect the motor axon. It can affect the neuromuscular junction, and it can affect the muscle fiber. Okay, so if there is a variant of motor neuron disease that your patient might have that appears to be primarily affecting the neuromuscular junction, you can see some of these neuromuscular junction type abnormalities during your testing. Okay?
So you're kind of differentiating between neuromuscular junction pathology as being something just unique to that area, maybe something not systemic, maybe something just unique to that.
Correct.
Versus a systemic global motor neuron disease.
Well, correct. And again, motor neuron disease affects a lot of structures. Okay. Mm-hmm. Patients that have ALS oftentimes have upper motor neuron signs. They have brisk reflexes. They have clonus. Okay. How is that possible? How can a patient that has motor neuron disease have symptoms of a more central disorder?
Because of all that it affects. I truly don't know, to be honest.
Okay, well, here's the answer. The anterior horn cell, okay, is part of what central nervous system structure?
The gray white matter.
It's part of the spinal cord.
Right.
Okay, so patients that have ALS and patients that have polio can have that combination of both upper motor neuron pathology and lower motor neuron pathology. Okay, what part of the motor neuron is lower motor?
Anything
post-ganglionic or
anything root or below?
Well, okay. We've just established that the motor neuron consists of the anterior horn cell, the motor axon, the neuromuscular junction, and all the muscle fibers that it innervates.
Anything motor axon or below.
Yeah, anything from the motor axon distal. Okay, so pathology affecting the motor axon, the neuromuscular junction, or the muscle fiber, that's all going to be lower motor neuron.
Got it.
Whereas if in a patient with ALS, especially early onset ALS, if the pathology is primarily affecting the anterior horn cell, they're going to have that combination of weakness, and they're going to have that, those signs of, upper motor neuron dysfunction,
Right.
such as brisk reflexes, clonus, spasticity. And then as the disease process progresses, they're going to present with combinations of this stuff. Okay, you literally could have a patient where in one leg they could have evidence of upper motor neuron pathology. Then you go to the other side, and they may have absent reflexes. Okay, so again, the reason that single fiber EMG can be useful in patients that have motor neuron disease is the neuromuscular junction is part of the motor neuron. Okay.
What would be the clinical indication that of, say, if somebody already has a diagnosis, would we be confirming a diagnosis or ruling it in or ruling it out? If they already know it, would there be a reason to be monitoring it?
Okay, so I've never seen a patient sent to me with a known neuromuscular junction disorder.
Got it. They're still looking. Mm-hmm.
Yeah, these patients are going to come in and they're going to say, do you know what? I feel great in the morning, but by 10 or 11 o'clock in the morning, I am so weak, I can't even function.
Right.
Okay. And some intrepid, family practitioner or some intrepid orthopedist is going to say they have shoulder pathology, or they've got a cervical radiculopathy, or something like that. So you have to be cognizant, okay, of, the signs and symptoms here. So a patient that has, myasthenia gravis, for example, do those patients do better in the mornings or do they do better in the afternoon?
Morning.
That is correct. Okay. A patient that has, Lambert-Eaton syndrome or systemic syndrome, do those patients do better in the mornings or in the afternoon?
I'm going to say afternoon.
Yes.
Because their body's able to get something better as a result of movement.
Good try and correct answer. Typically, last question here, can you see abnormal jitter and blocking in a normal muscle if your technique is good? Generally, you will not. Okay, so now we have, we're going to do what's called the exercise challenge here. And it looks like we may have had one more person come in here, although I don't see another name here. Okay, so one of the techniques that we use when we're suspecting that a patient may or may not have a neuromuscular junction disorder is what's called exercise facilitation. Okay, so this is an actual patient off of my system here. And so this patient came in and their complaints were weakness. They didn't have pain, they didn't have numbness, anything like that. They had basically weakness. So what I did, this is the median motor nerve here. So I achieved using 39 milliamps of stimulation, a maximum amplitude of 3.2, which you can see right here. Okay, and as all of you all know, that's low amplitude. Okay, because the normal amplitude for a median motor is somewhere around 4 to 4.5. I mean, something like that. Okay, but I was suspecting, based on her history, okay, she was telling me that, yeah, in the morning I can barely move, but by noon I'm doing pretty good. So what I did is I did 10 seconds of isometric thumb abduction. 10 seconds. Then I shocked them at the same intensity, 39 milliamps, immediately after, and lo and behold, I got a larger amplitude. Amplitude went from 3.2 to 8.8. Almost a 300% increase in that amplitude. Okay. So let me see if I have my questions here. Okay. So why? What about that 10 seconds of isometric exercise? Why would the amplitude get larger?
It was basically gathering resources and becoming more efficient in conduction as a result of continuing to basically keep those channels open. How's that for a
Close.
dark answer?
Close. So in the condition that this patient had, the problem was getting acetylcholine to be released. Okay. Mm-hmm. So when you do an isometric contraction, that's the same as doing like a tetanus type of reaction. Basically, you're flooding that neuromuscular junction with all the available acetylcholine. Mm-hmm. Okay. So you do 10 seconds, you fill that junction up of acetylcholine, then you shock them again, and you get that nice big amplitude there. Okay. Okay, so this is called post-exercise facilitation. Why? Okay. One, causes an accumulation of calcium, and that is what facilitates additional acetylcholine release. Okay, and when that neuromuscular junction is full of acetylcholine, all the available receptors on the muscle side, on that postsynaptic side, can have acetylcholine bind, and then you shock them and you get a normal CMAP amplitude. Okay, so what condition, based upon what we just talked about, which of the two conditions will you see this happen?
Oh, it's one of those two. Mm-hmm. The second one.
Is it the presynaptic or the postsynaptic?
Postsynaptic. Sorry, presynaptic.
Presynaptic. Okay, this patient probably has Lambert-Eaton syndrome / myasthenic syndrome. Okay, what do you think might happen if this was a patient with myasthenia gravis with a postsynaptic? Is it going to be the same type of phenomenon, or is it going to be different?
Different.
It's going to be the opposite, right?
Yeah, you'd have them exercise and they get weaker as they exercise.
And they'll get weaker, and what'll happen to your amplitude? Your amplitude's going to get smaller.
Fall.
Yeah. Exactly.
Mark, does it matter? Would it matter the time of day that you tested them?
No, not really. Okay. But what is important is that you're going to test a clinically weak muscle. Okay. And usually, unfortunately, in these conditions, oftentimes that's going to be a muscle of the face. Okay. In patients that have phenomyasthenia, what do we notice about their face?
Eyelid droop.
They have eyelid droop. Okay. So as some of you learned in your last training, what muscle are we going to record off of? Orbicularis oculi. Okay, we're gonna do this test off of the orbicularis oculi. We're gonna shock behind the ear. Okay, so we'll do a baseline, then we'll have them squeeze their eyes shut, okay, as hard as they can for 5 or 10 seconds, shock them again, and we'll get a larger amplitude at that point.
Dr. Brooks, you would never see anything quite like this with anything else, would you? This would just be neuromuscular junction, right?
Here's what I can guarantee you, okay? If you've done electrodiagnostic testing for any length of time, you've seen this patient. This patient has come in, okay? You guys have seen this patient in the clinic. You just didn't know what you were dealing with at that point.
Can I ask you a question?
Uh-huh.
We're calling it presynaptic because it requires the accumulation of calcium, because it's what's going on in that scenario that is abnormal. I mean, isn't calcium a piece that opens it up anyway?
Calcium is what is, okay, when you do a tetanic contraction to a muscle, or if you stimulate the nerve to get a tetanic contraction, you're shooting action potentials down that nerve, okay? And every time that action potential reaches the terminal part of that axon near the neuromuscular junction, it's going to cause voltage-gated calcium channels to open.
Right.
Okay? And then all the calcium flows into the axon. Once that happens, that is what triggers the release of acetylcholine. Okay, so the entrance of calcium is what is necessary to trigger the release of acetylcholine.
But it's taking more time in this scenario for it to happen compared to.
Well, what's happening is because you're doing a tetanic contraction as opposed to maybe just like a single stem, there's hundreds and hundreds and hundreds and maybe thousands of action potentials being sent down that axon. So the calcium is continuously flowing in, and the acetylcholine is continuously being released. And where it's being continuously released, it's filling up the neuromuscular junction with acetylcholine. So all the available receptors on the muscle side are accepting the acetylcholine. Okay, so you're artificially increasing the amount of acetylcholine that is being released by either stimulating the nerve or by doing a tetanic type of contraction. Okay, this patient could function pretty normal, okay, if they would do isometric exercises 100% of the time.
Right.
Okay, but how functional is that?
Right.
Okay, I guess you could attach a stimulator, to your facial nerve, and just continuously stimulate that nerve, and that'll make your droopy eyelids go away. Okay. But basically what you're doing here is you're artificially increasing the amount of acetylcholine that is being released, into that neuromuscular junction. And because that postsynaptic side is functioning normally, it's going to take all of that acetylcholine, and that's going to give you a much, much bigger compound muscle action potential, occurring on that side.
I'm still kind of lost. I mean, to me, that's just normal. It's just a question of how much, if you're flooding it, if it's an accumulation,
well,
versus the opposite where it's big first and then it depletes.
Yeah. Well, and again, if it's big first and then it gets smaller, okay, you're still flooding the neuromuscular junction with acetylcholine. The problem is there aren't any available acetylcholine receptors on the other side.
Right.
Okay? So you could exercise, but because the issue is with the ability of the acetylcholine to bind, as opposed to the amount being released,
right,
you're gonna see that decrease in amplitude. Okay. And you can do this if you're an astute clinician. When you manual muscle test a patient that has one of these conditions, say a patient with a presynaptic condition, say you're testing their deltoid. Okay. If you do a sustained manual muscle test contraction, what are you going to notice in that patient's strength?
For this one or the other?
This one, for this one.
They're going to get stronger.
They're going to get stronger. Yeah. Yeah. Okay. And that's going to be weird because normally patients, when you fatigue them, they don't get stronger, do they?
I always think of it as a recruitment issue, but maybe I'm picking up on something. They need an EMT.
Yeah. Okay. Patients that have this condition normally have absent or diminished reflexes. You know, you go to do a knee jerk and it'll either be absent or very, very much diminished. What do you think will happen to that reflex if you do 10 seconds of isometric quad set?
You'll get a good reflex.
You'll get a normal reflex.
Yeah.
So we have the ability as clinicians to sort of pick up on these things with really not even having to do any specialized testing. We're going to confirm what we think we're seeing by doing the testing.
Right.
Okay, but I guarantee you, any of you out there that have been PTs for longer than say 15 years, you have seen this patient. This patient has been in your clinic. You just didn't know that you were seeing them.
Right.
Okay, so let's go ahead and finish up here. Okay, so the last part of the challenge is you get to write an impression here. So let me present a case, a quick case here to you. Okay, so this is an actual patient that I saw in one of my clinics, a 61-year-old female with a 1-year history of weakness, usually after sitting and in the morning. Denied any type of pain or paresthesia, past medical history, hypertension, coronary artery disease, pre-diabetic arthritis, alcohol use, cigarette use for 40 years. She had had no imaging or other diagnostics, no atrophy, you know, anything weird like that. But she had problems walking, and she had problems getting out of a chair. Okay. And when I manual muscle tested her, she was very weak proximally, and she was still pretty weak distally. She either had absent or trace reflexes, but because I've seen this before, and because she told me that, you know, she was weaker in the morning or after she had been sitting, what I did is I did some quad sets with her. Her knee jerks became normal. And when I did, you know, some, you know, isometric exercises, her weak clinical muscles almost become normal. Okay, so right then and there, you know, I know what's, you know, or I have a good idea of what's going on. Did some sensory tests here. They were all normal. Here is my motors. Okay. The big thing that stood out is look at these amplitudes.
Terrible.
All these amplitudes are low here. There was a little thing happening here with her peroneal nerve. It had a prolonged latency. It had some slowed NCVs. I have a feeling that that was more of a function of the low amplitude as opposed to her having a problem. But, you know, she could have. Okay?
Yeah.
But what really caught my attention
My landlord, if you want to talk about an hour later.
is
I'll grab you as soon as I'm
that
done.
she
Are
had
you
low
still on the
amplitude.
phone?
I have a client right now.
Hey guys, can we mute? Somebody's having a conversation and I lost all that last piece.
Right before?
Yeah.
Okay.
Okay, so whoever's having the conversation, would you mute, you know, go ahead and mute yourself?
Sorry.
Okay. So again, with the motor issue or with the motor test, the issue was the low motor amplitudes. Okay. So guys, right now, okay, reflexes became normal with exercise. Strength got better with exercise. Okay. In combination with low, you know, motor amplitudes. What condition does this patient have?
Lambert-Eaton.
This patient has a presynaptic issue.
Yeah.
Okay. And when we do our nerve conduction and EMG, it's just going to prove that. EMG was normal. Completely normal EMG. Okay. So this is the patient that I showed you earlier. Okay. I I did exercise to her median, ulnar, and her peroneal nerve, and we had increases anywhere between 271 to almost 500% just by doing 10 seconds of exercise.
That's so cool.
Yeah. And I didn't have to do any repetitive nerve stimulation. I didn't have to do any single fiber EMG. You know, I didn't have to stick that needle net muscle and trigger it and look to see if it's getting larger or smaller. Just, you know, my clinical exam sort of pointed to where we were going, and we've already proved it just by doing this. Okay. But because this is so rare, okay, to actually catch a patient that has this condition that hasn't been seen by anybody else, okay, I'm going, hey, this is really cool here, okay? So I'm gonna do some more stuff here. So I did 2 types of repetitive nerve stimulation. I did some slow RNS at 3 shocks per second, and there was a decrement greater than 10% in two of these muscles, okay? That's abnormal. In a normal muscle, you can have a decrement of up to 10% in that amplitude. But if there's a neuromuscular junction disorder, it's going to be greater than 10%. And in 2 of them, we saw that decrement at the 4th stem, but after 10 stems, we saw it in all of these muscles, okay? Then I did some fast RNS, 30 shocks per second, okay? That's called tetanus. So what do you think is going to happen to the amplitude of that response?
Going to improve.
It's going to increase, because this is the same thing as doing exercise, right? It's the same thing as doing isometric exercise. And as you can see on all these waveforms, between the 1st and 10th waveform, we had an increment of anywhere between 68 to 250%. And that is a typo right there, by the way. Okay, in the deltoid, we had an increment. And guys, imagine this, okay? All of you have done the axillary nerve, right?
Yes.
Yes.
Where do we shock for the axillary nerve? Where do we shock to get a recording off of the deltoid?
Posterior deltoid.
No.
In the behind the
Nerves
pub.
point. Yeah.
Okay.
Yeah. We're shocking the plexus here.
Oh, yeah, that's right.
How do you think it feels to be stimulated at 30 shocks per second in your plexus?
Probably terrible.
She's not
It
loving
is-
you.
It was not cool. It is not cool. I wish here in our last training that we'd have had some time for everybody to experience that. But guess what? You will.
Yeah, I'll do it too, Vicky.
Yeah.
Appreciate you, Mark.
But it's clinically a very, very useful test. The only reason that I didn't shock her face is because she did not complain of any ocular symptoms. I mean, I was sort of, man, I was ready to go in and shock her face, okay? But she didn't have any ptosis. She didn't have any ocular weakness. She didn't have any facial, asymmetry, and so I'm thinking, okay, I'm gonna spare this woman, the pleasure of having her facial nerve stimulated at 30 hertz, okay, which is not fun.
At that point, you wouldn't need it, though, right?
I really didn't need to do this, but I did because it's always nice to have that second data point. Okay, we had done the exercise testing, and doing this, basically just cemented that this is a presynaptic, neuromuscular junction condition.
Well, it's definitely, yeah. I mean, it's definitely good that you did it, because there's going to be some other doctor or somebody who's going to be like, they just
exactly.
And then you got this now.
You know, and honestly, probably some doctor, you know, probably some neurologist up at
Right.
the university saw this report and said, he didn't do the eye, so I'm gonna repeat the study. Okay, you know, but you know, and you know what? I'm good with that. Okay, I mean, I'm good with it if the patient is good with it. Okay, so here's your challenge in our last probably 10 minutes or so. What were the abnormalities that we saw on nerve conduction? What was the primary abnormality?
Decreased amplitudes.
Decreased amplitude. Absolutely. Let's see if I can. Okay, so all motor CMAP amplitudes were diminished. Okay, so we picked that up with our standard tests. What else did we pick up? I mean, what else, you know, would we want to summarize in our NCS summary? What was the second thing I did?
You did a tetanic or asymmetric type of
Did the
contraction.
did the exercise test? Okay, and yeah, we saw that one uniperoneal nerve was abnormal. So we did. There was post-exercise facilitation seen in all those CMAPs that we tested. Okay, so basically what that statement means is the CMAPs got bigger after we exercised them for 10 seconds. Okay, we saw a CMAP increment when we did fast RNS at 30 hertz, and we saw a CMAP decrement with slow RNS at 3 hertz. Okay, so when you look at 5 and 6 and you look at number 1 and you put that together with that patient's clinical symptoms and your clinical findings of improved reflexes after doing exercise and improved strength after doing exercise, okay, you've got a strong suspicion that this patient has a neuromuscular junction disorder. What did we see with our EMG?
It's normal.
Nada. Everything was normal here. Okay, so this patient, this is a patient that you just saw. How do you write this impression?
I'll get the first sentence. This is an abnormal study.
Nice job there. Nice job.
Let somebody else take it from there.
Yeah. How would you write this? I mean, would you use diagnostic terms like Lambert-Eaton syndrome or anything like that? No.
No, presynaptic.
Yeah, because we don't know that it's Lambert-Eaton. I mean, there's 2 or 3 other varieties of that. So we're gonna. Who said on presynaptic? Was that you, Vicki?
Oh, I don't think it was me.
Who said presynaptic?
Yes, I did. I said it.
Okay. So, Mark.
Yes, sir.
Today's findings are suggestive of pathology affecting the presynaptic neuromuscular junction. That's all I'm going to say. Okay. And then I'm saying, suggest neurology follow-up. And then, I also threw in, because we did have those, abnormalities there, that, focal pathology affecting the left peroneal and tibial nerves, cannot be ruled out. Okay. I think that the reason that those 2 focal things were abnormal is because the CMAP amplitudes were, so small.
Yeah.
But the big thing here is we have to say that there's pathology affecting the presynaptic neuromuscular junction. Or you could say something like, today's findings are suggestive of a presynaptic neuromuscular junction disorder. Okay. If this was a myasthenia gravis patient, we would just switch pre to post. Okay. We're just not going to use terms like myasthenia gravis and Lambert-Eaton syndrome. What is the other, what's the second most common presynaptic condition?
Botulism toxin.
Huh?
I'm not sure. I'm just throwing out one that I think. A botulism toxin?
Botulism, exactly right. Okay.
Lucky.
Ladies, when you go in and you get your face injected, to smooth over those wrinkles. Okay. What causes wrinkles? The smooth muscle in the skin, okay, becomes tight and it sort of folds the skin up. So when you go have, and guys will do this too, okay, when you go have, botulism toxin injected into your face, what's it doing? It's basically paralyzing your muscles. It's inhibiting the release of acetylcholine
From the presynaptic.
from the
area.
presynaptic that cause those smooth muscles in the skin to contract and cause those wrinkles. There, okay?
Isn't that what Botox does?
That is what Botox does. Absolutely. That's what Botox does.
Well, and that was pioneered with the CP kids to cause
Exactly.
relaxation.
No, I was thinking of CP, not facial.
Yeah. Cosmetic
Then
Botox.
it became cosmetic.
Yeah. Yep. So again, when you go see your dermatologist or your plastic surgeon and you get that little, that little injection there, basically what's happening is that those muscles under the skin are being paralyzed. Okay. And it's permanent. Okay. Once you inject that toxin and it binds to the receptors that allow the release of acetylcholine, those receptors are done. Okay. They're never going to function again. So it's, you can see certain people, okay, that have had multiple injections of this because their face, their skin is drawn tight, almost like a plastic shrink wrap type of appearance. And if you look at them, because that Botox also affects some of the sympathetic and autonomic nerves also, they usually have a little bit of a glisten, to their skin also. Okay, so again, keep in mind that, botulinum toxin is a very, very powerful poison that paralyzes your neuromuscular system. There was a condition, we've all heard of, lockjaw, right?
Mm-hmm.
Okay, when you get these the bacteria that produces this toxin is called Clostridium botulinum, and if you get dirt into a wound, and this happened, this has happened previously in many of the earlier wars, wounds would become infected. This bacteria would get into the system, and this bacteria would grow within the body and release that toxin. And what would happen is that patient would become paralyzed. Okay, first their arms and legs would become paralyzed, but their cognitive function would be just fine. Okay, and then as more and more that bacteria grew and more that toxin was released, it would affect their ability to breathe. And these patients basically would suffocate, within a paralyzed body, but with full cognitive and mental ability. So it's very much a horrific way to die.
Is this also similar in botulism tetani as well?
Yes.
Okay. Like tetanus and.
Yep.
Okay.
Well, a tetanus, injection is, basically an antibody, or excuse me.
Yeah. But if you get the step on a rusty nail type of thing.
If you step on a rusty nail, that bacteria can grow within that wound and release this toxin. Yep, absolutely. Okay, so who thought that the neuromuscular junction was just a simple thing here? There's a lot of stuff going on in terms of just some take-home stuff from this evening. Is, again, keep in mind that if you've been a PT for any length of time, you probably have seen one of these patients, okay, and you just didn't know it. I know I have. Okay, I see probably 1 or 2 or 3 of these cases a year, And I've never had a patient referred to me to be tested for myasthenia. Okay. It's always been a situation where it's been a secondary type of referral for something that is affecting function, like shoulder weakness or hip weakness, and they want to rule out, a cervical radiculopathy or lumbar radiculopathy, something like that. And during my clinical exam, I start to notice subtle things such as absent reflexes or weakness that gets stronger as you do a little bit more of an isometric, manual muscle test. So with these patients, oftentimes before you even, get to the point of doing a nerve test or EMG on them, you're sort of going to have an idea of what's going on. And your testing is just going to confirm, exactly what you think is going on here. Questions? Anybody?
No.
No, I'm just thinking clinically, I have a client who really has struggled with strengthening. It's like, just getting her to squeeze or do is just labor intensive, and she hasn't really, it's like, is it a motivation issue? Is it a recruitment issue? It makes me wonder what's going on underneath the surface.
So have you tested them?
No, no, I'm just thinking of it right now, of course.
Yeah. Yeah. Again, keep in mind that our electrodiagnostic testing tools are just an extension of our clinical exam. Okay. And, certainly, if you think it's appropriate, then, certainly I think it would be incumbent upon you to, to go ahead and provide the patient, the diagnostics, that they need to get, to get you the proper idea of what's actually going on. Okay, so as usual, I have gone over time here, but that's okay.
It was good.
It was worth it.
Yep.
It was definitely worth it.
So I am doing I'm doing next week's webinar also.
All right.
And so it's going to be on CMAPs, and it's going to be on the clinical implication of low amplitude CMAPs. So I haven't even put it together, but it should be stimulating, just like this one is. Okay, guys.
Next week's a short week, so I don't.
This next week is going to be a shorter webinar because I don't know how far I can stretch a CMAP topic, out into an hour-and-a-half webinar. I doubt if I can do that. Plus, just like you guys, I'm going to have a short week, so my prep time. But one of the things I'm seeing a lot with cases right now, and Jennifer, if you're still on the line, you will attest to this.
Mm-hmm.
Just because you have a low amplitude CMAP, does that mean axonal? And Jennifer,
No.
That's right. That's right. It doesn't. Okay. So I'm going to stop there before I give away the whole thing, and look forward to seeing everybody next Wednesday evening.
Did you make that presentation just for me?
Actually, no.
Oh, bummer.
This is something that I've been seeing for months and months and months now. And of course, because our training says low amplitude means an axon loss issue. And with, sensories, yes, it probably is. But with motor, maybe not as much, because we have a better tool to assess, motor axon loss. And we'll talk about that next week. Then.
Thank you,
Can't
Dr.
wait.
Brooks. It was
Thank you.
amazing.
See you guys. Bye-bye.
Good night.
Bye.